Well, it is 8:01. If you want to, um, I'm just going to say a couple of housekeeping things. Welcome to the monthly ABIN webinar. We are so glad you're here with us this morning. This is a reminder that these webinars are recorded. By staying on this morning, you're giving us your permission to record this webinar. We will be posting it on the ABIN website. We're so glad you're here this October. Next month, we will be having Dr. Justin Hunt with Oak Street. And with that, I'm going to turn it over to Dr. Gibson to introduce our speaker today.
Thanks, Kim. Yes, we are really excited today to have Dr. Lori Sidari. We were just commenting, we've really become friends through our national meetings and commenting about how nice it is to get experts from around the country, because we're all learning about psychiatric collaborative care management, integrated behavioral health. And although it's definitely evidence-based models, the knowledge base continues to evolve, and especially how it's actually implemented real time. You can go to our ABIN website and see recordings of our webinars. Last month, we had Verna Little presenting a basic webinar, and then Laura's following, and then Dr. Hunt will be following next month. And this is extremely relevant. It was in the news yesterday, Arkansas Money and Politics, that the state has received the SAMHSA Collaborative Care Management Grant. So we will continue to be a resource for collaborative care management. But I'm especially happy to introduce Dr. Laura Sidari, who is someone who truly walks the walk. She's not just talking the talk. She's somebody that has lived experience in her professional and personal career, and she's board certified general psychiatrist, as well as specific training in integrated behavioral health and psychiatric consulting. She was in the Air Force as an Air Force officer and a psychiatrist, and she's got experience in college mental health as well as in specialty community mental health. And she's now the director for the Cayuga Integrated Behavioral Health Program. And it makes integrated behavioral health care available to thousands of patients across Cayuga in central New York. So this is not just an academic center. It's not just a research center. It's real world integrated behavioral health. And she leads a team of multi-professionals that include psychologists, social workers, mental health counselors, and psychiatrists. And is one of the places that is really effectively and efficiently combining the different models for integrated behavioral health, including, PCBH and collaborative care model, as well as other ways of using mental health consultants. So we talked earlier that she and we are members of the Collaborative Family Healthcare Association, which has a COCM special interest group, and she is continuing to serve as a national conference speaker, and also now offers nationwide technical consultative services as a Sidari consultant. So she's a great resource. We're glad to have her speaking for us for ABIN and in Arkansas, and glad to have all of you join us. So as we mentioned, if you're just getting on, put your name, your role, and your organization in the chat, and if you have any questions as we go. So thanks for being here, Dr. Sidari, and take it away.
Thanks so much, Dr. Gibson. It's so nice to be here. So I'll be talking with you all about combining models of integrated behavioral health care for effective primary care delivery. And, similar to the national work group that we do for collaborative care model with Collaborative Family Healthcare Association, we're going to be talking about both evidence-based as well as practical insights to help apply these concepts to the real world. In terms of disclosures, just like Dr. Gibson shared, I am a member and co-owner of Sidari Consultants. Some people do pay me to do educational things and whatnot. I'm not getting compensated for this, and a lot of the things that I do, I ultimately don't get paid for. It's just what I really enjoy doing. In terms of webinar overview, key things I want you to take away are gaining an understanding of the continuum for defining integrated care. We'll also talk about describing the evolution of integrated care specific to the United States. We will emphasize PCBH and collaborative care model, COCM, as two main models that have come to the forefront of our United States integrated care provisions. We'll also outline a conceptual framework for how do we create cohesion and effective cross-model integration when we have needs specific for an organization. And we'll finish up by talking about Cayuga Integrated Behavioral Health as a narrative example. This is less so to be like, this is the way you should do it. It's more about showing in the real world, how can we apply these principles to meet needs that are local based, as well as recognizing things that may translate over to multiple other areas. In terms of a little bit, one of the things that Dr. Gibson and I have shared is that both of us have had kind of a meandering path to get to integrated care. And I would say that's probably the norm rather than the exception. So if you're here today as somebody who's seasoned in integrated care or knows nothing and are here just to be introduced, just know that you're in good company either way, because many of us didn't wake up maybe as like children or in high school saying, oh, someday I want to be an integrated consultant working as a behaviorist in an integrated care setting. But we developed that passion as part of our journey. And that's, I think, a huge part of doing this work. It's this idea that we really believe in what we're doing for our patients, and we really believe in what we're doing personally and professionally as individuals, as part of a team. I started out my career as a joint civilian and military resident coming out of medical training at University of Buffalo in 2012. And so that gave me exposure, especially in the specialty mental health environment, to both community medicine as well as military medicine. And that's a really interesting place to try and integrate different skill sets because the missions are very different. In the military, we're really working on a resiliency model, recovery, really trying to focus on strength-based more than disease-based focus. Whereas in the community models, we're really working on more of that disease-based piece. And then as a military officer, I wore dual hats. So I had to be both a psychiatrist, but then also serving the military, which sometimes was a challenging balance to march. Working both hand in hand with commanders and other officers, as well as working with some incredible active duty members struggling or really trying to find their footing as part of the military. So starting out, I really had that focus in specialty mental health, working with a lot of trauma survivors, working with a lot of specialty mental health needs. And a part of my personal journey was unexpectedly in 2017, my oldest son died at the hospital where I worked. And that really was a big piece in my career in terms of changing my relationship with my work, working predominantly with those who are trauma survivors, working with other members of the hospital, and having to sort of re-envision and rethink what is the best way, especially kind of with this immediate life change, for me to be able to still grow and serve and care for a population, while also recognizing that there may be some areas that now are different for me. So I was introduced by one of my colleagues to BHOP, which in the military is a PCBH model that serves the family practice area. And I started doing a little bit of curbside consultation. So, taking questions from what the primary care doctors had. And from there, providing consultative advice in the moment, and then also doing some electronic consults. And that was something that I really experienced and enjoyed that I didn't even know was out there. And so over the course of my military career, I really increased that amount of time that I was spending in the integrated behavioral health space. And that kind of became like a little bit of a niche of mine. And it was unexpected to find that new area that I wasn't exposed to earlier in my career directly, but was aware of more peripherally. After I finished my time with active duty, I went back home, which is Ithaca, New York, and Cornell University is the major university in addition to Ithaca College in the region. And I had a colleague who had an integrated behavioral health PCBH program set up, and I was like, hey, are you looking for a consulting psychiatrist? Would that be possible? And it just so happened that that worked out. And so I started right after my military career doing some more integrated psychiatric consultation as part of a PCBH team and really expanded the capabilities of that. So I was doing direct evals, one-time evals, in addition to curbsides, in addition to electronic evals. And because this was another closed system, we didn't have to worry as much about reimbursement or other pieces like that. The big part for care delivery in this was actually psychiatric extension of care. Cornell was dealing with some difficulties with a loss of psychiatric providers, and their primary care team had not needed to prescribe psychotropic medication, including SSRIs, for 20 plus years. And so my job was doing education and training for that team, really helping to try to reasonably extend to the top of primary care scope the capabilities of that department. And over the course of a year, we increased the psychiatric care capabilities by 5 times of a psychiatrist. So essentially, you know, with my role in that team, the way that we measured that performance was increasing the ability to serve patients to the equivalent of 5 impanelments of psychiatrists on that team. It was a really cool experience to be able to creatively use those skills that I had started out in the military and then really grow them in a real world environment, yet not yet needing really to do much with financial pieces. The sustainability piece was always something that daunted me a little bit more. I also did a little bit of specialty mental health, helping out with some of the students who had more complex care needs. And that was helpful both for showing the things that helped as well as hurt with integration. With that, sometimes as I started to take on more patients, I noticed some of my PCPs were more so consulting with me for accessibility, trying to get patients in for my empanelment, which actually decreased some of the effective utilization of integrated care, and was something that really caused me to take a closer look at, is that something that happens on a national basis, and see that that is something also that we just struggle with, trying to figure out how to utilize the continuum in other care models as well. During this time, I also had an opportunity to get trained in collaborative care model by Dr. Lori Rainey, who came and introduced the model as part of the mental health review and improvement process for Cornell University. And that really was my first experience back in 2019 with collaborative care model outside of the routine trainings you can get through American Psychiatric Association. So a really cool experience from there. In the middle of the pandemic, I really wanted to think about reworking some of the things that I was doing. I'm a mom with 3 surviving young kids. So in addition to my son who passed away, I have 3 young children. And the pandemic was a really challenging time for a lot of us who are working, as well as parents trying to figure out what to do. And I was finding that in the integrated care space at Cornell, I was being pushed more and more towards that specialty mental health piece, despite the improvements. And I really wanted to take that skill set that I had learned and honed and was passionate about to the next level. So for my local health system, we have a not-for-profit professional corporation run by a MD, Dr. Marty Stallone, who's an internist who also has an MBA. And he runs overall for our health system. He directs overall operations for the health system. And so similarly to kind of like Cornell, I pitched him this crazy idea, do you guys have a role or a need for integrated behavioral health? I know that you have really limited referral network. They didn't have any in-network specialty psychiatry services at that point, really just community mental health with our Tompkins County Mental Health and 1 not-for-profit, everybody else fee-for-service. So really, really limited resources. And put together a pro forma, learned how to do that from other mentors and experts across the country, kind of taking a look at what other people did and reaching out. And from there, put together an integrated behavioral health program that I both direct and serve clinically as consulting psychiatrist. And with that, it's really given me an opportunity to pursue this dream that has developed since my time early in the military, where I am solely working in integrated behavioral health, and I have a small number of one-time evals that I do, but I'm really able to fully dedicate my time, energy, and skills to primary care integrated behavioral health. Applying this to some concepts, let's talk a little bit now about some fundamentals that then we can use to put those together in practice as we look at the narrative model of CIVH later. So keep in mind, before we even get started, the definition of integrated care is a common place of confusion. Keep in mind, integrated care is not one definition, it's actually a spectrum, because integrated care is shared components of care along a spectrum. So with that, we have the least integrated elements of care, which is not always the least complex, but it has the fewest number of shared components on the spectrum, all the way up to the most integrated, which has the most number of shared components on a spectrum. When we're looking at this, it's important to keep in mind what's off the spectrum. So minimal collaboration. So this would be like having a specialty mental health clinic separate from your primary care clinic. You don't have any exchange in records. You don't have any exchange in any information. You simply share the patient, but there is no shared components of collaboration. That is off of the chart for integrated care. Looking on the chart for integrated care, our lowest level is coordinated care. So this would be like we have a record release in place, or we occasionally talk about the care, but all of the other components in terms of the treatment plan, in terms of the EHR, the location, everything else is separate. One level up is co-located care. This is an area of common confusion for integrated behavioral health in primary care. This is where you have a specialist, like a psychiatrist or like a psychologist, who's located in the same area as a primary care provider. This would be sort of like the medical equivalent of having a pulmonologist or a rheumatologist in the same clinic as a PCP. So this helps with sharing location and being closer in proximity of care, but the care plans and the care delivery remain independent and separate. And so there is still that greater fragmentation of care. When we get into the higher ends of the spectrum, we have partially integrated care and fully integrated care. And this is really where the interesting things happen. If you look at where things are really effective, both practically in real life examples, as well as in the literature, this is for collaborative care model, the 90+ randomized controlled trials that show just for depression alone, efficacy across many different populations. This is really where we have very highly coordinated, clear care delivery with decreased fragmentation of care, ability to meet the quadruple aim, because we are sharing the most number of care components commensurate and equal with that functional foundational team. So that would be same patient, same place, same EHR, same care plan, same major care goals, but parts of that plan may be divvied out to different members of the team to best serve the needs of the patient. When we think about this, it's also helpful to think about typical scopes of care, because that also impacts workflow development, that impacts care delivery, and an understanding of what we're doing. Care teams automatically are going to default to referral-based care, co-located care in terms of understanding. So these lower ends here are really specialty mental health and primary care. They have two different scopes. They have different target populations and different workflows. There's advantages and disadvantages to that. On the other side, we have a shared patient-centered medical home. So where we see integration, particularly fully integrated care models being most effective, they're building off of the best practice principles from the foundational team. So when we have integration in a primary care environment, there is a shared scope of primary care. That doesn't mean we have the same scopes of practice. So as a general psychiatrist with board certification, that is my scope of practice. But when I'm delivering care in a primary care environment, it's different than what I'm doing in a specialty outpatient clinic or an inpatient specialty clinic or an inpatient specialty unit or a residential. So those are all different scopes of care, even though my scope of practice is the same. There's also shared workflows. There's a shared population served, even if we may divvy off different care needs, there's still the overall patient pool that we're sharing. And so we're really thinking about those best practices for the foundational team. Another way to kind of look at the spectrum, and this is from Dr. Radsliff's team, related to looking at spectrum of care need complexity. This doesn't line up the same as spectrums of care for integration. So remember, shared components on a spectrum for integrated care, which does not align the same as the spectrum of complexity. So when we look at sort of the foundational piece, number 5, this is community care, like self-management and monitoring, social and community supports. Then we start to get into primary care. So universal screening via mental health vital signs, watchful waiting, systematic monitoring with matched up care response. This is like routine monitoring and preventative care, which is a key piece of primary care services. When we get up into intervention-based integration, the next level up in terms of complexity is focused assessment and intervention. And these are personalized as well as coordinated approaches. And this is where we see PCBH, primary care behavioral health, and COCM collaborative care model come into play with measurement-based care, focused intervention, and/or health and behavior. One level up is chronic care management. So unlike focused care needs, like what we see for number 3, this is where we really have maintenance care for primary care needs. And so this is especially has good evidence base for diabetes management, for instance, these chronic conditions that have the same sort of process that you need for looking into them and monitoring them. That's best to have a wrapped shared care team approach. It has some similar models, by the way, to collaborative care model, which was built off of chronic care management, but the delivery is such that instead of a focus on acute needs and on sort of like changing needs and getting you better, the focus is on maintaining you and preventing you from decompensating, needing high level of resources like ER evaluation. And at the very top, this is where our specialty and referral-based care would fall. Both higher level of care like hospital, as well as outpatient, where it may be more specialized, but not needing those higher levels of intervention and support. And when we look at primary care integration, this is really where a lot of the sauce is. This is really where a lot of sort of the evidence-based action, the improvements, the funding, this is where a lot of this activity is happening in terms of integration. When we look at integrated care, it's also helpful to appreciate that there's 50 years of evolving experience, practical and evidence-based research behind integrated care. This isn't something that just came up yesterday. I had, when I started at Cayuga, multiple people ask, Dr. Sidari, did you make this up? Like, this seems like a great model that you just created, because that's the level of familiarity that the kind of like local region had with integrated care. But no, this is not, my new idea. This is something that's been around for a very long time and has a lot of evidence in different spaces, but is still sort of making national spread into all parts. So in the 1970s, this is really where we have our first large-scale example of an organized program that had medical and mental health collaboration. In the 90s, this is where we started to look into some of these key leading model development, and they really developed separately in parallel with different key stakeholders. So we had PCBH, primary care behavioral health, that really came out of the psychologist camp and psychologist literature with American Psychological Association. And we had collaborative care model that really came more out of the American Psychiatric Association with psychiatric-based integration. There's many other models that developed. I'm just sharing these really as some of the highlighted ones that have some of the most robust evidence behind them in terms of evidence-based and evidence-informed approaches. And this is also where Collaborative Family Healthcare Association was first established in the mid-90s. In the 2000s, this is where we started to see, especially in these closed loop systems, getting really effective at integrated care. So we had integrated care becoming mainstream in the military and VA government programs. We also started to have avenues to deliver this care with CPT and CMS codes. And this in particular focused early on with health and behavior codes for psychologists. And this is in particular where the evidence base really started to evolve for COCM, collaborative care model, where the IMPACT trial, which was the first of many, showed tremendous benefit compared to care as usual, which would be any referral-based care, any care that the provider typically would do, with superior outcomes for the quadruple aim. In 2010, this is where we started to have greater financial sustainability come into play. So the Affordable Care Act was enacted at that time, and that's where we started to get much better pipeline and promoted funding for integrated care practices. And Arkansas, similar to New York State, really we've had a lot of increase since 2017 in capabilities, because this is when we had introduction of COCM codes in 2021. And now we're getting this state by state spread where we're turning on those codes for Medicaid, and commercial payers are really following suit. And we have a much better financial sustainability for the still predominantly fee-for-service models across the United States. There's other opportunities coming down the pipeline in terms of grants, in terms of value-based care. So this is just really a snapshot to help you understand the evolution as opposed to being all-encompassing. When we think about these ways of organizing different kinds of integrated care, I pointed out two of the big ones that are helpful practically when you're putting these together. So that is the number of shared components on the integrated care spectrum, and that's also the complexity of the care needs. But that's not the only way we can organize integrated care. And you'll, those who are coming to CFHA, there's going to be an ELO related to this, looking at a systems-based model approach as opposed to just models of care, to help determine how can we start to sort through and combine different elements of integrated care to meet organizational needs. So with that, care needs served is another way to divide it up. The team composition. So let's say you only have access to psychologists and or social workers. You might design your integrated care team differently, or maybe you have a training program for psychiatrists. That might be a different way that you would design your integrated care system. Accessibility. So if that is a priority, let's say access is a problem, you don't have any referral-based care options, that might be a way that you would prioritize different models for your care system. Funding modalities, that's a big part, especially if you're not grant funded, if you're really doing still more fee-for-based and or mixed value-based payment funding. And then scopes of care. So are we all sharing within primary care scope, or are we going to have different scopes of care? We'll all have different scopes of practice, but how are we going to unite versus define separately the services in terms of scope? When we think about this, just to kind of have another snapshot, I really want a key take home for you to take away is fully integrated primary care behavioral health is where the strong evidence base is. This is where we see efficacy, sustainability, and accessibility, as well as high satisfaction for providers and patients when it's done well. And some of the common elements across multiple different models are these key things in the center. So these are patient-centered, care models, population health-based. So we're focusing on treating an overall population, not just one individual by preference or need. It's a primary care team. This is measurement-based. So we're truly understanding if somebody's getting better versus not just subjectively, but using mental health vital signs like our PHQ-9s, our GAD-7s as a strategic tool as one component of our assessments and our interventions. And then it's evidence-based. So we're doing things that are shown to be effective through high-quality research, particularly randomized controlled trials. And so with this, some of the opportunities that we see that are published again and again, and I see also as part of running an integrated team that's fully integrated in primary care, we then provide options for mild, moderate, severe primary care conditions. So there's options for everybody on the spectrum, not just severe needs. We also augment the most common care needs so that we're actually meeting the overall needs by bulk for the population. There's diagnostic assistance that often is here. Safety planning help. This is a huge thing that my PCPs really love. This ability, especially in office, to have those supports. There's acute as well as routine supports. These are also typically focused intervention. So different from that chronic care model part, these are time-limited, brief, focused interventions for physical and or mental health conditions. So it includes, but is not limited to, mental health as a part of behavioral health intervention. So there might be brief therapeutic interventions, lifestyle change supports like exercise and or nutritional diet, treatment monitoring, as well as psychoeducation and general education for clinical needs. Close care coordination. And this overall kind of individually and in total helps to streamline PCP care and offset the burden. So while the PCP is still typically leading the patient-centered treatment care plan, they can carve off pieces that maybe they could do but don't have time to do, or maybe they don't feel as skilled in doing those things. So this, when done effectively, can really help with care delivery. In terms of looking at impact for referral-based care, so for co-located and or community referral care, this is shown to decrease the need for specialty referrals, not by extending the scope of primary care, but allowing you to practice to the top of your scope, as well as preventing progression to severe mental illness. But it does not fully solve for this. So when we're setting expectations up, the expectation is not integrated primary care. It's going to replace the need altogether for specialty mental health. It's just that it is going to serve the vast majority of those needs and decreases the burden towards specialty mental health. So we're really focusing on this area. This question comes up a lot, all right? So I've had this question all the time. Dr. Sidari, why don't you just take our 10 most severe patients in a practice and call it a day? Why don't we just have co-located specialty care? I would feel more comfortable with that. My patients prefer to see a psychiatrist, not me. Well, besides just my own personal experience and opinions, this is very clear in the available evidence base as current. This is no better than care as usual. It runs into the same problems as care as usual, even with co-location, because it is still an external referral. So what happens is it's lacking in examples of effective care models. We end up with short-term benefits, immediate buy-in, people are very happy, they're sending people there, and then it's got no long-term solution because we end up just with a 6-month or 9-month referral wait list in our clinic as opposed to in the community. And full integration has been shown, including in this 2023 study by Dr. Henry Chung, to be superior comparative to co-located options looking at a shared Medicaid population, specifically in New York State. So while we don't have pure head-to-head studies, we're really lacking an evidence base to show that this would be the best way to utilize limited services that we have, limited resources that we have, if we're going to best serve a general population. The other thing to keep in mind is that co-located specialty care can interfere with uptake of other integrated models. Going back to my description of my time at Cornell, that was a huge part of the problem that occurred, where by having that pathway to have patients sent over to me or to be seen by me, it changed the relationship for consultation. So instead of trying to learn and augment and be able to do work to the top of the scope, the incentivization becomes ultimately, how can I get the patient in with the psychiatrist? That's not true for everybody, but it becomes a significant burden on the system, and it taxes all sorts of different pieces of an effective, fully integrated care system. So, the other thing to keep in mind, how do we do referral-based care? Referral-based care is our traditional medical model, systems-based approach where you have one defined need, like let's say you have a MI or you have a kidney disease or something like that. So you're looking for specific markers of severe disturbance, and then you're carving that part of the care out. With behavioral health and mental health, it becomes more complicated because it's never just one thing. The biopsychosocial model, the nature of behavioral and mental health, it's part of everything. So it's really hard to identify markers of severe disturbance. It's very subjective unless you outline that very clearly and everybody's on the same page. And then also you get the patient and provider preference piece that comes in. I would prefer to do that. I would like to do that. That becomes a little bit more taxing for mental and behavioral health referral versus other referral models. And so, we end up with those same problems just in the same clinic as opposed to in the community. Another way of looking at this, why integrate? Again, hitting home, this is the most effective way to treat a general population. So putting this into a pictorial form, if we have specialty mental health, we have high impact intervention for a small population, very defined care needs versus a diverse, varying in needs, varying in demands in much larger population for primary care. And so what we see with full integrated care, there's frequent opportunities for engagement and re-engagement. If the patient doesn't want to engage that day, that's fine. They can come in the next time and want to work with the BHC or work with the care manager. Not a problem. It's accessible as needed. So maybe they don't need that care today, but maybe they lose their job or have difficulties with pain or a new diagnosis, and they want care in 2 months, or they need care in 2 months. It's helpful for a diverse range of concerns that include but are not limited to mental health needs. And so when we look at this kind of on a picture, if we're looking at behavioral health being the orange plus the blue, keep in mind mental health is one subset of behavioral health. So we're able to care for all of these different needs of the population. But when we translate this over to specialty mental health, we're really working with standalone referrals. So if the patient doesn't follow through with the referral, it goes away, or they have to be re-referred. That makes difficult for accessibility. These are also specific to mental health concerns, so we're not going to get all that nice stuff in the orange as well. And when we look at national data, the typical rate nationally for follow-through on a referral to specialty mental health is 50%. And of those who actually land, the typical number of visits attended is less than 2. So when we look at how that translates over to care provided to a community comparatively, we're looking at about this comparatively. So a much smaller number, even if you have similar number of resources, are going to be cared for. Again, it's not to villainize or make this bad, it's to just really understand where are we going to put our energy and our resources. This is another question, kind of building across it, why Dr. Sidari, wouldn't you then just like serve that very defined patient population? So when we look at national data connected to the service reach for psychiatrist supports, there was a nice out of the APA 2019 article related to typical empanelments for psychiatrists, and it's small. These are typically 150 to 250, looking at both fee for service through community organizations, as well as those who are private pay, private practice. And what we also see is 44% of psychiatrists as of 2021 with national survey data do not accept commercial insurance, compared to 10%. Versus when you look at care reach for a one full-time equivalent for me, so just doing clinical work, not having anything for administrative, this would be my service reach. So 1 FTE of my time is equivalent to serving a 40 to 60,000 primary care patient population. And that's because one full-time psychiatrist or psychiatric consultant is serving 30 plus PCPs. And then there's also additional multiplier effects, because part of the investment of the health system in me is strategic workforce training. So I do a lot of work hand in hand, training and onboarding, developing skills for my PCPs and my behaviorists. When we look at barriers and facilitators to this is really well studied. There's a lot of different articles on this. And the things that come up again and again for integrated care predictably also play out in the real world. I've seen all of these things as part of being an integrated behavioral health director. One is insufficient staff numbers. There's always never enough staff. There's never enough staffing for behaviorists, for administrative supports. This is something that we deal with on both sides in terms of the integrated team, as well as our primary care partners. There can be very commonly, unless clearly outlined, disagreement about care roles. And this comes from automatic assumptions about care roles that are very different than what we see in the integrated care space best practices. And this also comes from if you have multiple team members and not everybody is sure what they're doing, and there's overlaps in terms of scope. Information sharing challenges. This is actually more recently related to confusions about HIPAA as opposed to actual sharing challenges. So keep in mind, there are HIPAA limitations on process notes and certain aspects of specialty mental health care. But when we deliver integrated behavioral health, we do not do process notes. And so those should not be in your medical record. But nevertheless, this can come up. What should I include in the record? What should I not? Who should have access to that on the team? And that can be a barrier. Financial sustainability is a big one. A lot of us are trained clinically who have gone to medical school or gone to specialty clinical, programs. We've not been trained how to have conversations with upper leadership about financial sustainability, but it is important for us to appreciate that this is a conversation we need to feel comfortable with and fluent in. And it is a reasonable conversation to have. There's also still stigma around, should we, value paying for healthcare as like a lab or a pill versus therapy and mental health care, and really like advocating for the fact that as part of healthcare, it is very important to value mental health care alongside, not below, physical health care needs. And then, of course, workflow and logistical obstacles. It's important to create local workflows that work for your team. That can be challenging, though, if you're using a national model for integrated care. So you want to be sure that the workflows and the structure works for your team and organization in terms of helping to streamline coordinated care, and then also still allowing for personalized care. When we look at organization theory literature, there's really those two camps. You want to have some workflows that are very refined, very clear for your most common care needs that decrease the amount of personalized communication that's unnecessary. But for individualized, close care planning, specific patient needs, you still need to have that personalized interaction. So we want to be thoughtful for each. In terms of facilitators, one of the biggest and most important things that you can do is create championship at all levels. One of the most important things you can do is creating championship at all levels. And ultimately, this does not rely as much on the behaviorists. This relies on our primary care partners and our upper leadership. If this is not supported by your upper leadership, one of the best things that I have as part of my team is strong championship from upper leadership. I have strong championship from my PCP partners. If you do not have that, you are going to have a very hard time with spreading integrated care. It ultimately is not made and broken on mental health professionals. This is made on your foundational primary care team. The other thing is making sure you invest in care training and orientation. This is something often overlooked. It's not fee for service, but this is how we can streamline and augment our workforce and also retain skilled people. And then warm handoffs. So important, that personalized relationship with providers, that personalized relationship with team members, whether that's virtual or in office. It's vital for the success of integrated care. When we think about different models of integrated care, this is a nice analogy that came out of CFHA. We've got a lot of different models to include, but not limited to PCBH and COCM. And when we outline these different models, it can be really helpful to think about these as like different fruit. One of the surprising things that I discovered kind of like getting familiar in the integrated care space is sometimes we can have deep encampments in one type of fruit. So I am the COCM camp, or I'm the Med FT or the PCBH camp. And when we start to compare fruit about which one's better, it becomes a silly argument, but it's something that can happen. Like the apple is better than the lemon. This one's better than the other one. The problem that comes up with that is it's really not about inherently which one is better. It's about the recipe that you're doing. It's about the care that you're delivering. So in some cases, we might need the strawberry and we might not need as much of the orange, or maybe we need both together. So it's really helpful for us to think about these not as which one's better or worse, but which one is needed at a given time or place to effectively deliver integrated care. When we look at this, just one example to kind of outline would be looking at the different components to compare. And that's, more so to understand those differences to then strategically utilize those versus comparing which one's better. So if we take PCBH and COCM, the reasons for support are a little bit different, with PCBH really serving any care need and putting flexibility at the top, versus COCM being really defined for certain diagnoses, particularly common mental health diagnoses, with very structured and less flexible but safe wraparound support and measurement-based care for care needs. The care composition is different, with a BHC being present for PCBH versus really having a multi-team model that includes requiring a psychiatric consultant with a care manager. For the schedule structure, typical BHC schedule is half open booked, half scheduled, and so it's really more of a clinic-based schedule versus care managers often will be directing and more flexibly doing their own schedule. And then the billing is different. So PCBH CPT codes are typically billed out under the behaviorist, health and behavior codes and or psychotherapy, versus COCM is all incident to primary care. So it's billed out by the supervising PCP with a once a month bundled care code to capture all of the services. So, why should we be considering an integrated care model? Benefits are it gives you a roadmap for setup. It's supported by the evidence. You have established reimbursement models, so there's sort of like that plug and play approach that you can use. But the challenges are you're going to get gaps in population coverage, and sometimes it's hard to retrofit those into your care system, and you might ultimately need multiple models to meet your population health needs. In terms of other things here, considerations for blending models, there's pros and cons too. So the benefits are it expands your care options, you can serve a greater population. This is especially helpful for primary care, but the challenge is it often takes upfront investments. This is why sometimes it can be better served at a local level where you can work more personally and do that, but that's high intensity upfront with resources. That requires also having a unifying care delivery framework to reduce the potential for care fragmentation or duplication of services, care confusion. So the more models you have, the more complex and confusing it is, and more important it is to have an infrastructure, but also the possibilities are greater. And so if you want to think about this with our fruit example, it's kind of like creating the bowl, all right? So when we create a unifying structure, it's like putting all of these different fruit together, still on their individual pieces in the bowl. And the things that can define that bowl are things like the population health approach, primary care model. You're doing universal PHQ-9s or GAD-7s for treatment, measurement-based care. You're doing focused treatment. You're looking at financial sustainability, health system priorities, multidisciplinary team. So there's lots of opportunities for unification, but it has to be strategic and deliberate. In terms of taking a look at where your organization is, there's a lot of different tools that you can find. I really like this GROW tool that was put together by Project Team with AIM Center, Qualis Health, Nicole Center for Healthcare, and the Commonwealth Fund. And this can be really helpful, especially if your organization is early in the process and you're really trying to kind of figure out where to start. So let's take a little bit of a closer look at Cayuga Integrated Behavioral Health in the last bit of time that we have. So my team, we have a fully integrated behavioral health service team supporting affiliate primary care teams. So we affiliate with specific teams that are primary care, and we deliver as part of that PCBH and COCM blended models of care. In terms of our care system, we're located in the Finger Lakes region, New York. So it's this central region. We are not close to New York City. We're about 4 hours away. So a very different population. We have a small urban center with lots of rural underserved around, very limited referral-based opportunity network for mental health. We're a multi-specialist outpatient healthcare group. We're not for profit. Most of our fee-for-service model is, most of our service model right now is fee-for-service. We're trying to work towards more performance-based contracts, but right now they're network-wide. So that limits really opportunities on the individual provider level. It's more of looking at the overall network. And we have no grant funding whatsoever for behavioral health. Everything was internally funded through not-for-profit, funds from the organization. And now we're fully self-sustaining with our fee-for-service model. We're mostly insured for our population, which is a benefit, 98%, but about half are Medicaid/Medicare and half are commercial. And we have a really diverse population. So Ithaca brings in worldwide, students for Cornell University in particular. We also have Ithaca College, so a high college student area, lots of professors from all different parts of the world. And then we also have very underserved populations as well. Individuals from very low SES, very destitute populations. We have rural and urban, pediatric to geriatric needs. So a pretty diverse population. With this also, so in terms of service performance, we've been working since February of 2021 when I came on board, and we have had service delivery clinically since August of 2021. Right now, we have a cohesive practice model that is sustainable and replicatable across the network, established in 3 primary care clinics, and we also have a rheumatology care pathway. In addition to myself, I have 2 psychologist assistant directors, each that run up the PCBH and COCM arms of services. We have a program manager that unites us, and then we have 7 additional professionals. We have 6 behaviorists and 1 additional psychiatrist to put our team composition to be that. Our population penetration has steadily been going up, 2.6 in 2021, just in the last little bit of the year, to 9.8. And for COCM, we've had more than 880 patients enrolled, more than 500 case reviews as of September, and our population penetration is only going up. We have 3 additional practice sites anticipated by 2024. In terms of sort of the roadmap to what I've done with my team, the first several months from February to August was service model development. And this was really doing needs assessment across different parts of the organization, looking at what resources we had versus not, having a core group of key health system stakeholders from diverse different areas of the health system to come up with our mission and our vision statement, our top priorities, our care endpoints that we wanted to really shoot towards, and then really looking at what would be the best way to have care delivery. This is where we identified PCBH and COCM in combination being the best approach, as opposed to just choosing one or the other, because the gaps that we found with each one. And then we also were able to have a reimbursement model that was projected. So we actually had not built any single codes for mental health or behavioral health ever in the health system when we came in. So we weren't really sure. So we had to use a lot of technical consultation through New York State Office of Mental Health to help inform that. From August to August 2021 to 2022, this is where we really started to get in the weeds with our clinical workflow development. And we had 2 pilot practices at practices that reflected similar sort of like types of primary care practices that we had in the system. And that really helped us to identify what worked and what didn't, and get really efficient and effective at working through common care problems. This is also where we started to put together our data dashboard, put together supervision structure, and really see where did we need to invest energy and where could we, not do as much. And now we're really in the growth phase and clinical process refinement. So now we really have a model that works for our care system. It's getting really good buy-in. In fact, I have more clinics on the wait list wanting to get our services than we can actually fill. And so we have been able to have a much more rapid ramp up with 4 additional clinical sites wanted in the next 2 years, large demand of services, high buy-in. And so I really look at the success that we're having based upon all of the investment that we had from 2021 to 2022. All right, so kind of to put all this together, the distinct elements that we have for our program, in terms of the fruit, we have PCBH and COCM, and this allows for distinct elements of care accessibility. So our PCBH model, our BHCs are only in office, and then our COCM is fully remote. We went back and forth a lot on that. So we had technical consultation with Verna Little through New York State. That's how I first met Verna. And, we asked the question, would it be best to have providers that do both, like behaviorist that does PCBH and is a care manager, or separate? And this really led to this decision. These are the things best to keep as separate fruits so that you can define separate workflows, streamline care, and still get both care needs met. We also have different target care needs, that more broad approach for PCBH versus very targeted COCM, and billing and coding structure is different. Our care approach with sort of how they're working with patients is different. And then in terms of the bowl, the things that we've really seen as part of like that secret sauce that helps things work really well, we have a shared PCP consent process. This is really important. This is important on multiple levels. So even though it's not needed for billing for PCPH, it's really helpful to define they are not just a co-located specialist. They're within scope of primary care. Having the PCPs give that consent phrase and have those conversations with the patients also reinforces their role on the team as the care leaders, establishing and working and leading the care team with the patient-centered care plan. I had one of my PCPs early on be like, I don't ever have to consent when I send them to the pulmonologist. Why would I have to do that for behavioral health? It was like a perfect example of some of the ideology challenges that we have early on and the importance of creating processes that help to reinforce the good habits that we're wanting to have anyways. The shared consent process is billing-wise required for COCM, and so this also allowed us to be able to be in compliance with both administratively and clinically that care model. We do universal screening. Every patient at every visit for primary care is offered a PHQ-9 or GAD-7. PHQ-9 is part of their mental health vital signs. We're working on also putting in GAD-7. And that's something that, just like blood pressure, they can decline that, but they're given an opportunity every time to be asked about their mental health needs, and it gives an opportunity to both decrease stigma as well as have care access. We also have defined only primary care scope. This has really helped to cut down on drift towards specialty mental health. It's allowed us to get really defined and good at what we're doing, while also, that is sometimes a hard conversation that I have to have on a regular basis, and we still have to rely on good relationships and partnerships with our community referral partners to be effective. And we offer focused, goal-oriented, problem-based approach, and we have really robust investment in program administrative supports. All right. Any questions or thoughts?
Hey,
Wow.
Laura. Oh, Kim, I had a question. Sorry.
Absolutely. Please, Justin, I was just going to say, let's open it up for questions.
Laura, I had a question on the PHQ-9. Are you putting that data as discrete within your EMR environment or your system, or is it going on just a flat file PDF and scanned in?
So we've really moved more towards that electronic delivery as much as possible. And we even have a flow sheet for it. So similar to like blood pressure and BMI, like you can see it actually on a flow sheet. There's the ability to deliver that through the portal. And then we also have taught our providers how to verbally administrate that as part of a structured clinical interview. And so as you're asking the questions, you're also putting that in. So we really try as much as possible to put that in that like kind of radio answer form as opposed to a scanned in form, so that it can be seen in a really nice flow sheet for us to faster track and faster recall on that. That's a great question. I think that's an area there's a lot more needed to be done, because some EHRs are better than others. We have MedEnt, and so that wasn't naturally suited for that, and it took a lot of investment with our like kind of EHR partners to do that, which was time and challenging. So I just want to acknowledge that is something that I think there's much still to be desired in a lot of those of us that can't afford Epic or like really, really, really nice EHRs.
Thanks, Laura. What can you say that EMR again?
We have MedEnt.
Okay.
You probably have not heard of it. It's not very
We have it
common.
in Arkansas, but hey, every week I learn of a new one. So this is my week to learn for a new one.
There you go.
Thanks, Laura.
Thanks, Justin. It's not the worst, but it's not the best. I hope there's no MedEnt folks on here.
Any other questions as we wind down? We appreciate everybody attending, and Dr. Sidari, this has really been an excellent presentation. And even as I have heard you speak before, there has been a question put in the chat. Can you share your workflow sheet?
Is that for the PHQ-9 GAD-7 piece that you're requesting, Sherry, or like for clinical workflows?
Clinical workflows.
Yeah. And actually, let me just show real quick if folks have a second.
Sure.
You'll get a brief preview to the CFHA presentation. If anybody wants to see, we're going to be, my team and myself are going to be doing a blended care presentation there. Let's find where that went. So we really try to keep our workflow infrastructure very simple as much as possible, because it's already complex enough. So the key workflow that we show, and when questions come up, honestly, we can bring it back to this workflow time and time again, is this one. So all of our workflows are built off of these three keys. Every patient has to start with establishing with their primary care provider. So when we get a phone call, why can't I just see the behaviorist? I don't want to see a PCP. It's because our care is delivered as an extension of primary care. So it's important that we establish with our primary care provider to establish the care need and the care plan. And then the patient receives prior to their visit mental health vital signs, namely PHQ-9, but often the providers, if they've seen them before, might put in I want an audit C, I want a PCL, I want a GAD-7 or other pertinent measurement-based tools. When the PCP meets with the patient, they start by diagnosing the health problem. And we're big on, it doesn't need to be a mental health diagnosis. It's the behavioral health problem. It might be sleep problems or bereavement. It might be work stress. Those are all okay. Like those all apply. And so they establish the treatment plan. That might be as simple as warm handoff to BHC. Doesn't have to be very complex. It just has to be, what is the role of integration if needed at all? What's the care problem? The PCP, after they diagnose the problem, establish the treatment plan. If they think any part of integrated care might be helpful, they provide the informed consent process with a DOT phrase. The DOT phrase I've got, the DOT phrase we adapted from the American Psychiatric Association COCM toolkit. And it basically says, I've given consent for you to meet with and speak with relevant behavioral health, mental health specialists that may include a consulting psychiatrist. There may be copays or other cost sharing as part of this visit, typical to other healthcare needs. And that's really it. Like those are kind of the key pieces that you have to have for the consent part. Sometimes patients need clarification that the role of the consulting psychiatrist is for the PCP, not for the patient. And they're like, so can I just see the psychiatrist? We also have from our PCP champion, like a after visit summary piece that just outlines some of the key in common language parts for the patient. And often the conversation will just come up, like, let's say they're saying, I'm having trouble with fatigue. You've shared today, you're having a lot of trouble with energy. I've got a member on my team that really helps specialize and work with people on helping them feel better with energy. Would you be willing to meet with them for today? So they get that started with the behavioral health consultant with a warm handoff. And we try to do that every time we possibly can. And then with the warm handoff, we can deliver that consent phrase with the behaviorist there as well. So it's less important how that happens and exactly all those pieces, but more so that it does happen and it's a conversation. If that's been done before and somebody didn't want to consent, that's okay. You just say, provided informed consent, patient declined today. Because if they message back in the portal or call back and they change their mind, there it is, ready to go. They don't need another visit. So the key part of the 3 keys is not being reductionistic that you have to do X, Y, and Z. It's more of you just have to meet these milestones. How you meet the milestones can be different. And then the PCP prescribes a care option. They don't know what to do, send them to the BHC. That's okay. The BHC will help them sort it out. And so the whole time the PCP continues to monitor the patient's progress and adjust treatment as clinically indicated. And at the same time, we have behaviorists, primary care behaviorists specifically, provide targeted assessment, treatment, and supports that best fit with the PCP treatment plan and the patient's care needs. And so all of our workflows are built off of this. What do I do if a patient calls in crisis? Go back to the 3 keys. What do I do if a patient, is having trouble after a year and they want to come back? Go back to the 3 keys. Do we need to redefine the health problem here? If the person's just calling the clinic and there's a mental and behavioral health need, we triage it through nursing triage the same way that we would other healthcare needs. So it's really helpful to have this sort of conceptual framework that then we build all of our primary care processes in alignment with. This is really our only integrated care specific workflow. Everything else is PCBH best practices that our team helps to inform, but we really work off of PCBH best practices.
That is really helpful. And this has been a great conversation, and maybe we'll have to have you back for a part 2. And also we're throwing out there advertisement for the CFHA, where you will be giving I think it's a 3-hour training, early learning. And we will have a recording on the ABIN website of this, as well as some materials that on the website for your access. And so if you have continued questions today or at any point, feel free to email Kim or me, and we will follow up and get answers for you. But it was really great hearing the progression, not only of your personal story into integrated behavioral health, so that we can all be reassured that there's not a college degree in this. You learn it on the ground, and it's an ongoing process. And then also the development of your program, that you're using evidence-based models and building on the research that's been done, and then practical application in your clinic. So we really appreciate it, and look forward to talking to you again.
Absolutely. Thanks so much for having me, and right back at you. Looking forward to be invited back another time.
Thank you, Dr. Sidari, and we'll see you in Phoenix.
Absolutely. Can't wait.
Take care. We appreciate your time.
Bye-bye.
Thanks, Kim. Bye.